So our very special guest today is Dr. Mark Melin, and he's a surgeon and medical director of the M Health Wound Healing Institute and an adjunct associate professor in the University of Minnesota Surgical Department. His interests and educational niches include management of lymphedema, lymphatic stasis in the wounded patient, the endothelial glycocalyx, adjunctive micronutrient and bionutrient application to wound care, wound pH and biofilm management, and emerging technologies in wound products and wound technologies. He also participates in the educational activities of the Wound Fellowship Program. His additional interests, educational efforts, presentations, and research include human physiology and adaptability in the weightlessness of space travel and its translation to improving patient cares on terra firma, and achieving nominal human function in environmental extremes and the extremes of healthcare. He resides in the suburbs of Minneapolis, Minnesota, with his wife of 33 years, Cindy. They have 4 grown children and 3 daughters-in-law. 2 children and a daughter-in-law are also in medicine. They have 3 rescue dogs and many books. Thank you very much indeed for coming on today, and very much looking forward to your talk. Thank you.
Thank you, Rowena. Very kind of you. I appreciate it. I always want to comment, none of this is ever a solo sport. You know, we work closely together. I've had the great privilege to overlap with Rowena on a couple projects and with Heather Hettrick, who's done at Nova Southeastern. And so some of the concepts I'm going to talk about are Heather's, and I'm going to point that out. So we're going to talk a little bit about microgravity, and really we should be calling that weightlessness. Microgravity is a misnomer because when you're on the space station, you're still subjected to 90% of the Earth's gravity. It's just you're falling around the Earth so fast at 17,500 miles an hour, seeing 16 sunrises, 16 sunsets a day. It's like going down an elevator shaft. So that's why you float and you're weightless, but you're still exposed to 90% of the Earth's gravity field. We're going to talk lymphatics. We're going to talk this concept veil, which means veins, arteries, integument. So that'd be fascia, skin, bone, and then lymphatics. What is biotensegrity? What are the fluid shifts that occur in weightlessness? And then talk a little bit about endothelial cell function. Now there's 60,000 miles of veins, arteries, and lymphatics in the body, and about 3 trillion endothelial cells. Think of them as the bricks that line the roads throughout that entire 60,000 miles are incredibly important. So the lymphatic system is a crucial part, underemphasized, undereducated. I applaud Rowena for even bringing this to a highlight for you as students, because this is the future. If we can enhance lymphatic functionality, we can cure a lot of diseases. We can reverse atherosclerosis, we can reverse obesity, we can impact cancer rates, we can excuse me, we can improve treatment of venous leg ulcers, which are so-called phlebolymphedema. So the important part of the lymphatic system, it's not just waste transport, it's actually an incredible component of immune function and soft tissue regeneration. So when your lymphatic system is functioning well, you actually can heal wounds much quicker. Now, there's really some classic functions of the lymphatic system. There's this balance between interstitial fluid, so all the fluid that's not within the lumen of a vessel, and then there's protein within that, and then there's water. Now, when it gets into the lumen, especially within the lymphatics, now usually the valves of the lymphatic system are wide open and fluid is always flowing forward. When you get some distension of the lymphatics, when there's too much fluid in the interstitium, now you actually get the valves to close and you get diastolic contraction because of that distension, much like a ventricle in the heart. So that diastolic contraction is lymphangion contraction, a lymphangion being defined from valve to valve. And this is what ideally keeps everything in homeostasis or in balance. Fat absorption in the intestinal tract is totally dependent upon the intactness of the lymphatics within the mesentery. And again, we talked about how important the immune system is. So within the immune system, there's a couple things to know about. There's a bunch of T cells that function. T regulator cells have now been shown to be a very important part of this cycle of immune overreaction with inflammation, development of proliferation and fibrosis. So trying to stop T regs from overacting, and it's kind of a double-edged sword. The other big players are the macrophages. So there's the M1, M2 pathway. And here's the way I remember this. M1 looks like an eye. So that's inflammation. So if you have too much M1 cells, it's pro-inflammatory. M2 is the inflammation quenching, the tissue restoration pathway in the macrophage component. So all of these are within the immune system. Again, the T regulators, the M1s, the M2s, they all play a fine, kind of like in a symphony, they're all very orchestrated because you have to have some inflammation to kill pathogens, but then you have to be able to recover and go back to homeostasis so you can restore tissue functionality. So with chronicity of a heightened immune system, then you get things like fibromyalgia, you get chronic pain, you have recurrent cellulitis within legs. So it's this really fine-tuned balance that's so critical to integration. It is very important for reversing cholesterol transport. Now, when you think about the aorta, that's the size of your thumb, so 2 centimeters, the lumen of the aorta is not the functional part of an aorta. It's actually the vasovasorum on the outside. So that's, if you look at what the initial damage to the lumen of the aorta is or causing an aortic aneurysm, it's the vasovasorum not functioning correctly. It destroys the elastins, the collagens, the aorta may dilate or vice versa. If the lymphatics within the vasovasorum aren't working correctly, now you have deposition of atherosclerotic or proatherosclerotic plaque, so LDLs, IDLs, VLDLs, etc. Just like it can lay down that stuff, it has been shown beyond a shadow of doubt that you can actually have reverse transport of these to improve long-term outcomes. So supporting a healthy lymphatic system is very important. Now, in the brain, it used to be thought there was no lymphatics in the brain. There's actually 2 different systems. One is kind of like that classical, the meningeal lymphatics, but then there's this neoclassical one that Jeff Illig described and Martina, oh my gosh, I'm blanking on Niederhofer in 2011 when they were at the University of New York, called the G lymphatic system. This is more like a sweeping wave of fluid that comes through the brain. Perivenous, periarterial, comes down the nodal system into the neck, and that's what sweeps out beta 40 and beta 42, the amyloid components that make plaque and Alzheimer's disease. So they're very, and the G lymphatic system functions best when you're sleeping supine. So a lot of my wound care patients sleep in a chair. So it means not only are they not clearing their brain of buildup of proteins that can make their brain not function well, they're also not getting resetting of their legs at night because their heart's always above their legs. So it's a very important question to ask your patients are you sleeping in a chair or are you sleeping in bed? And then also being aligned with your circadian rhythm. Circadian rhythm ideally is kind of when the sun goes down, when the sun comes up. That's what you're trying to match to get your body to function the best. And that's how the G lymphatic functions. Now, interesting, if you're an astronaut in space, you never sleep supine. You're always almost like sleeping upright. Therefore, it's really impossible or very difficult to clear those amyloid 40 and 42. And they've done studies, and I think I talked about this one at the end, where when an astronaut returns from 6 months on the station and they measure their amyloid 40 and 42 levels, they shoot way up. So it's like all of a sudden they're sleeping in the weighted environment of a 1G bed, flat, and now their G lymphatic system kicks in and it clears everything out. The other thing that you see in astronauts is a lot of cerebral interstitium edema, so they retain fluid. So there's a lot of things to work on with the G lymphatic system within astronauts. So clinically, the problems with the lymphatic system, it's either you have a lymphatic system that doesn't function correctly or it's overloaded. So primary lymphedema is because you're genetically predisposed, where your lymphatics just don't function correctly. You may have lymphangians that can't contract. You may have valvular dysfunction. It may occur right at birth. It may be noticed. It may be noticed as you reach puberty. It may be noticed after age 30 or 40, after 30 or 40 years of gravity affecting your body, and now you're just genetically predisposed, and all of a sudden it starts to fall. So that's primary lymphedema. Then with secondary, because there's a secondary cause, so it could be radiation therapy, taking all the lymph nodes out of an axilla for breast cancer, trauma, sepsis, chemotherapy. So there was a secondary event or bad veins. So venous hypertension can drive lymphatic dysfunction from overflow. And of course, solid organs like congestive heart failure, renal failure, pulmonary hypertension, liver failure, cirrhosis, all of these can develop into development of lower extremity edema. And then always look at the medication list. So one of the ones we always stop in patients is called amlodipine. Amlodipine is a calcium channel blocker, and it causes diffuse hyperpermeability. So it's really good with dropping blood pressure, but it also causes a lot of swelling, well known. So in our wound clinic, and it's a good medication, not everybody gets swelling, but of course we see a skewed population of people with wounds. Well, they got wounds because they can't get rid of their swelling. So we stop amlodipine in everybody. Now, these are really end stage elephantiasis, stage 3 patients with lymphedema. And you can see these really, really tough skin changes. This is because there's ischemia at the skin level. So you're not getting enough oxygen nutrient delivery in the blood vessels the size of 1/3 your hair, which is 5 microns. That's where all oxygen nutrient delivery comes. So when you don't get good oxygen nutrient delivery to the skin, this is the result. You get disordered growth, dysfunctional growth. You grow these papillomas and verrucas, and it's really altering on lifestyle. And you can't smell this, but I'm sure if you've had the chance to be around patients like this, it smells. There's so much dead tissue, and there's hyperkeratosis, and it's all over-infected with Pseudomonas. So it's a quality of life thing because it's really embarrassing for those patients. They're always leaking fluid, and these patients are really in need of our help. So Heather came up with this veil concept probably about a decade ago. Again, venous, arterial, integument, lymphatic. If you want to treat the lymphatic system, you have to understand how it's integrated into the integument and how it works with the arterial and how it works with the venous. Dysfunction in one system can lead to dysfunction in all the other symptoms. Now, they may be subclinical or they may be very, very dramatic, just like pictures we just showed. But here's a good picture of where the vein is, where the artery is, and then that kind of bluish looking is the lymphatic. Now, what's really interesting about this is look at all the tentacles of the lymphatics wrapped around that vein. The detail on this is so gorgeous. So so much of that vein is covered with lymphatics because if there's venous hypertension, it has to pick up that extra fluid so you don't overload the interstitium. But also look at there's lymphatics almost encasing the artery. So this is why lymphatics are so important. Now, it was hard to see these images way back in the day, and this is why the lymphatics have always gotten, third-class citizenship in terms of understanding, educating, testing, and treating. But anything that is that diffuse in the body clearly has to have a very important role in what happens. So the concept of all edema is lymphatic fluid. Now, some people bristle a little bit at that concept because to call that everything you see, if there's swelling, it's automatically lymphedema. I put it into the realm of, well, is it reversible or irreversible? Is there a short period of time of congestive heart failure that we can diurese and it goes away? As a patient on dialysis and now it's permanent, is a genetic component, and oftentimes there's a lot of overlap in these types of things. But it's very clear that if you have edema in the leg, it's because the lymphatic system simply can't keep up with emptying it. So we talked about some of this, but the pathophysiology of lymphedema explains propensity for why people get cellulitis. If your lymphatic system is static, so it's engorged with fluid, the lymphangions aren't contracting, that means your immune system is static. It's not going to be able to do its surveillance things, therefore you're more prone to developing cellulitis. So dermal lymphatic stasis is a predisposing factor to developing cellulitis, and every episode of cellulitis destroys more dermal lymphatics. So it's why it's so important that patients wear compression. They use micronized purified flavonoid fraction to make their lymphatics function better. They drink fluids. Diuretics do not work because all you're doing is pulling the fluid out, but you're leaving a protein-rich, almost like oatmeal within the subcutaneous tissues. That oatmeal doesn't want to move through the lymphatics. So actually, counterintuitively, drinking fluid, a good 1.5 to 2 liters a day, can help your management of lymphedema. And then certainly, Rowena and I were talking at the beginning, ask your patients about salt use. Too much salt in the world, and salt definitely makes lymphatic function worse. So again, lymphatic stasis is a chronic inflammatory state. It results in increased pain. It results in increased development of wounds. It results in increased development of cellulitis. So when we see patients like this, they might get manual lymphatic drainage. They need maybe lymphedema pumps. They need compression. They need to elevate their legs. We need to look at all the micronutrients that can help these patients heal up. I'm going to skip past a couple things here and get to the next concept. So when when an astronaut goes into space, it takes about 8 minutes from launch to get into low Earth orbit. During the first 24 hours to 48 hours, there's a 2-liter fluid shift. So about a liter from each leg up to the upper torso, head, and neck. And this has been known about since the days of the Mercury program, the Gemini program. And they've worked really hard trying to understand this. What are the countermeasures that can be done to help mitigate against this? We're going to talk a little bit about this as we go, because when you have that much fluid change up to your head and neck, it results in decreased your taste buds get altered. It can impact your retina, and you can get retinal swelling. It can cause a little bit of brain fog. Your sinuses can get full. Your hearing can get muffled. Most astronauts take up an extra pair of glasses, knowing that their vision's going to change, and they're going to need glasses while they're on the station. Some of this, again, because of the retinal changes. This all together is called SANS, S-A-N-S, or spaceflight associated neuroocular syndrome. Now, this was inspiration for a crew that flew in October of 2019, and Jared Isaacman was the pilot. Haley Arsenault, who's in the front, is actually a physician assistant at St. Jude's, who was the youngest girl to go into space, and she's the only one to go up with a prosthetic in her leg after management of osteosarcoma as a young girl. So she went through, I think, at least 2 operations. This is all public knowledge because it's in her book called Wild Ride. But it was interesting to hear them talk about the symptoms. It's just this pooling in your head, like when you hang upside down in your bed. But you have to kind of find a way to just ignore it and work through it. About a day later, it kind of balances out and you don't notice as much. For some people, it balances out. For some people, it really never balances out. And that's probably a genetic component. And NASA's been showing the what are called single nucleotide polymorphism changes between astronauts that can actually make it more difficult to balance this out over the course of time. But now look at their faces. They've been in, I think they were up about 48 hours at this point. You can see every one of their faces are a little bit swollen as compared to being on Earth. And if you're feeling a little bit foggy, like today, I got this little bit of a cold, my head's a little bit full, and it's not my A game when you're battling this. Yet to be up on there for 6 months in a row and deal with this every single day, and they're doing incredible work, research. They got to repair the station. They got to do EVAs. If you constantly feel like that, it can be result in an impairment for your high functioning level. Now, I always say astronauts are almost like Olympic athletes. They're incredibly trained. They're brilliant people. They train very hard, and they're ready for everything that a checklist can bring them. So as professionals, they're able to work through all this and be highly functional. Now, this concept of biotensegrity, again, kind of like veil, biotensegrity is where there's this tension between all the tissues that makes them work together. So much like if you put up a tent, most tents nowadays have maybe 2-3 poles, and then you stretch on the fabric, and that tension holds the poles in place. That's tensegrity. So that opposing forces that stabilizes everything. Now, biotensegrity is what's happening in our body. And so how is biotensegrity changed when you're either on a deep sea dive or if you're in low Earth orbit? Because there's shifting of all these fluids that are not natural. So here's the complex slide. This came out of Sarah Swart and Scott Smith and their team down at NASA to talk about the multi-hit theory with spaceflight associated neuroocular syndrome. To break down the components, if we look to the left, it's the retina and the choroid, and then you're seeing a 5-micron vessel because you're looking at one red blood cell. So this is the smallest blood vessels in the body, and you can see that there's activation of metallics matroproteinases. Those are the things that break down collagen, elastin. This is some of the things that alter how a vessel functions, and not for the good. It's inflammation. So you see this bulging within the disc, you see this bulging within the optic nerve, and they follow it with OTCA. So they're actually now have a device up there that can do the angiography and look at the retinas with incredibly high detail. And then if we follow over to the right, this is actually showing what happens with when you get L-arginine. It ideally ends up being processed into something called nitric oxide. Nitric oxide does a couple things. It vasodilates, so you get better arterial flow for healing, and then you get better immune function, and you get better lymphangion contractility as long as it's not too much. So if there's decreased nitric oxide, not only do you lose vasodilatation, but you also lose scavenging of reactive oxygen species. That's a double whammy. And then if you look right below the vessel where it says fluid leakage, that is the edema you're seeing in the astronauts, especially in the head and neck. So there's hyperpermeability within the vasculature that contributes to all this. So it's happening in the skull, it's happening in the brain, it's happening in the face, it's happening in the upper torso. So all that fluid leakage then overwhelms the lymphatics, and the lymphatics can't pump enough. Now, if you think about teleologically, we as humans are on the earth. So we're used to standing up, so we have gravity assist to drain. But if you're up in space, you lose that gravity assist, so everything comes up, but your lymphangions aren't strong enough to contract to pull it back down. Versus if you look at a bat, and Alan Hargan's taught me this out of San Diego. He's got about $3 million in grants with NASA. He's a phenomenally smart gentleman. But when they look at bats that hang upside down for 18 hours a day, the bats' heads don't swell. That's because a bat's head and neck lymphangions have great contractility like our legs. So that prevents the bat's face and the bat head from swelling despite the fact they're hanging upside down 18 hours a day. So we need to figure out if we could get the robustness of a bat's head and neck and upper torso for lymphangion contractility, maybe that would help us better deal with some of this. You can also see above this where the genetic component is with the single nucleotide polymorphisms. The astronauts that go into space that have higher homocysteine levels, homocysteine of itself is just a marker, but the higher homocysteine levels usually then was what alerted them to the fact that there's probably these single nucleotide polymorphisms that make an abnormality. So it's all part of something called one carbon metabolism. Again, genetic component. And then if we look at the space station itself, you can see there's astronauts can develop insulin resistance, arterial stiffness, increased radiation exposure, and they're not even outside of the Van Allen belt. And then they live in an environment that's 10 times the normal CO2 levels, which can itself lead to a little bit of vasodilatation. But they've done a study at the European Space Agency looking at exposure to high CO2 levels, and they felt that wasn't a significant component, but it may very well be part of it. Now, this is just to compare side to side. So I blew up from Scott and Sarah's study on the right-hand side, and then the left-hand side is showing a study that was published in 2018 that looked at, as fluid flows across arteries, it's called shear stress. And as it goes across the arteries, that's what stimulates this thing called the glycocalyx. It's like little sugars inside the artery, and that's actually what's causing nitric oxide release. So it's the shear stress or fluid moving across, because anytime you have fluid not moving in a vessel, it's either going to clot or it's going to cause inflammation. It's always bad to have fluid not moving inside a vessel of the vein, arteries, or lymphatics. So as the shear stress moves fluid across, it increases nitric oxide, it decreases the reactive oxygen species. Now, when you look at the pathological part, here you've got shedding of the glycocalyx. Now, things that can cause shedding of the glycocalyx are smoking, high arterial pressure, high venous pressure, chemotherapy, some medications, trauma. So high salt now has been recognized to change the glycocalyx. So these are things that we deal with a lot in our patients that have peripheral arterial disease. All of those patients have a shed or a dysfunctional glycocalyx. This again, here's Macon Niedergaard, again with Jeff Elligo was one of the first people. So Macon Niedergaard had published this with some of the world's brightest people on the SANS issue with Dr. Woston, Dr. Mader, Dr. Gibson, and they were looking at, is there an ocular G lymphatic system that's actually contributing and dysfunction with that? And so this is their theory that why they get contribution to an enlarged retinal nerve, and why you get these fluid changes and dysfunction. Again, in space, you're probably getting some level of microvascular stasis and things not moving well. Way over towards the right, you see this thing called a perivenous space, or PVS. That's what's been correlated with people getting Alzheimer's. As those spaces or perivenous spaces increase, that's fluid coming out through hyperpermeability. That is sine qua non with development of Alzheimer's disease. And this is actually what they're seeing in some astronauts that have been up on the station for prolonged periods of time. They're seeing increased perivenous spaces. This would all get back to the theory that there's some dysregulation even in the ocular and the brain G lymphatic system that's contributing to why they're seeing these changes on MRI. So this is clearly a gap in medical school. You know, my two sons, my daughter-in-law who are in medical school, they got hardly anything on the lymphatics. They learn more from us sitting down over Christmas, et cetera, talking about this. But again, the lymphatic system is fundamentally important to cardiovascular disease, infection, immunity, cancer, and also contributing to obesity. So the classic Starling force is that there's always fluid moving out of the artery. But what we know from the revised Starling curve is because of the glycocalyx, which acts like Gore-Tex, fluid actually, once it goes out, can't come back in. And if that fluid can't go back in, it has to be picked up by the lymphatic system. This is actually what resulted in the renaissance of the lymphatic research. And now we just see escalation of number of peer-reviewed articles, both for lymphatic disease as well as for the endothelial glycocalyx. So here's kind of a classic patient I deal with. And when I talk to these patients, say, do you have swelling? They'll say, I don't have swelling. And you do the finger push and it leaves this huge pit. So not only are physicians underdiagnosing this, nurses are underdiagnosing it, patients don't even realize it exists. But think about how much extra fluid is in that leg. And that can be uncomfortable, and it certainly can compromise your arterial flow at that microvascular level and end up with increased risk of wounds. So again, we talked about primary and secondary. Many secondary likely have a component of a primary with a subsequent tipping point. And gravity over life is a prolonged tipping point for many of our patients. So the mnemonic for the endothelial glycocalyx is EPIC, E-P-I-C. So endothelial cell cytokine production, again, nitric oxide. It's a permeability layer. It's Gore-Tex-like. It's inflammation quenching and coagulation regulating. And Rowena, I'm watching my time here because it's quarter till. I'm going to go about 5 more minutes and then we'll do QA. Is that okay with you?
Yeah, you can probably go a little bit longer than that, I think. Thanks, Mark.
Go about 7 minutes?
Yep.
Okay, perfect. Thank you. So here again is that EPIC, the endothelial cell function. Again, this is a 5-micron vessel. And look at it, looks like the seaweed, right? So as there's shear force or flow across that, it moves that seaweed back and forth. That's actually called mechanical transduction. So you're taking energy of flow, transmitting it down the stalks of these sugar husks into the endothelial cells, and that's what's producing the nitric oxide. So, and then again, it with the hyaluronic acid and the albumin component, this is what causes the permeability prevention, the coagulation. It covers, literally covers the von Willebrand factors and other factors that contribute to inappropriate coagulation, and then it quenches inflammation. So if you look at people with rheumatoid arthritis, with diabetes is a very inflammatory disease process. All of their glycocalyxes are not functioning correctly. Again, average 60,000 miles, 3 trillion endothelial cells. And a report just came out this year from Dr. Chiasani out of Italy with Joe Raffetto and Stanley Roxon, showing the first demonstration, human demonstration of the endothelial glycocalyx within a human specimen. Really exciting report. We kind of hit on this hard. This is from Enno Ebong's lab in Boston. And this is the lab that I actually was very fortunate to be able to participate in a mouse carotid study to look at restoration of the glycocalyx. This just shows the components within the glycocalyx. So heparan sulfate, albumin, chondroitin sulfate, hyaluronic acid, and think of it as a lawn on top, a grass on top of your lawn. If the grass is cut too short, the lawn, the dirt there will basically dry out and be non-functional. This is exactly what's happening inside of our arteries when you get something like atherosclerosis. So this is why smoking's so bad. Now, this is within a blood-brain barrier, and the glycocalyx is what is a significant contributor to the blood-brain barrier. So unless you stain correctly, so you can see with lanthanum staining, you can see this, it almost looks like dryer lint within this artery. And then if you stain it without lanthanum, it actually degrades the whole thing. So people didn't know about this for a long time because they were using stains such as formaldehyde, alcohol. It would just wipe away this entire sugar layer. And that's actually what glycocalyx means, is sugar husk, because many of these are complex types of sugar. The other analogy I use is it's like a computer. So the computer has hardware, software, and a power source. The glycocalyx has a hardware, those hard things called the glycoproteins, proteoglycans, the glycosaminoglycans. Those are all those components that wave in the shear. And then there's the software component, because clearly genetics and epigenetics can play a part in how your glycocalyx works. And then the power source is that flow across the surface. Again, this important word called mechanical transduction, or the energy transfer, which really connects then all this concept of tensegrity, biotensegrity, and veil. A mechanical transduction brings it all together. Here's another great example: shear stress impacting glypican-1 and heparan sulfate. And you can see as that lever moves back and forth, that's what's coupling endothelial nitric oxide synthetase. That's why you get nitric oxide production. So this is how you prevent hypertension. It's by producing enough nitric oxide. Nitric oxide is critical to body function. Now, if you haven't heard of piezo 1 and 2 channels yet, this is something to keep a close eye on. Nobel Prize in Medicine out of Scripps, and I'm going to blank on the gentleman's name that did it. Really smart guy, but he found these piezo 1 channels. They also contribute to nitric oxide production, so there's redundancy in the system to have multiple ways to produce nitric oxide. And these actually feel force, so they're mechanical sensors. So my question is, what happens when you go into space? Because if you go into space, now you're unweighting all these mechanical sensors, and if you need tissue weight on piezo 1s to produce nitric oxide, and now you unweight everything, how do you get it to produce? Now, I think exercising probably makes a difference, and clearly when you do high intensity interval exercising, that produces more nitric oxide. This just shows that piezo 1 channels and piezo 2 channels, they're throughout every part of the organ system within the body. So again, this is just emphasizing again that whole concept of shear stress with the biotensegrity and the importance in terms of production. This shows normal conditions with glycocalyx, severe conditions. Now, the other thing that happens is when you have severe, that's a negative. Here's the study that shows that with high intensity interval training, you can rebuild your endothelial glycocalyx. So this is why exercise is important. This is why encouraging our patients, especially our aging patients, because as you hit about age 70, your glycocalyx starts to get thinner. So drinking good water, low salt, walking daily, eating lots of flavonoids, lots of fiber, feed your microbiome, all very important to overall health. And here you can see crew up on the space station doing their resistive exercise. They're working out typically, I believe, 90 minutes to 2.5 hours a day to maintain and not end up with significant muscle or weight loss. 3 last slides and we're going to stop. This is just, I just want to show you the density of lymphatics within the dermis. So here's a patient I took care of, and I scraped off all the hyperkeratotic tissue. Each one of those is a dermal lymphatic that is engorged with fluid. This is why our patients are getting cellulitis. And when you look at the microarchitecture, it's like, it can't go anywhere because the fluid's not moving. This is why like manual lymphatic drainage works. This is why compression works. And this is why on a lymphoscintigraphy, you'll see all this dermal backflow because the fluid is literally just congested in that one area. And then if you put congestive heart failure, pulmonary hypertension, venous hypertension, any of those other states onto this, it makes it just dramatically worse. So compression is a critical component, as well as walking, as well as good clean water, decreasing sodium are all incredibly important. And with that, Rowena, I'm gonna see if we have any questions so you guys can enjoy the rest of your Monday.
No, thank you so much. That was amazing. So much fantastic and really, really interesting information, and I think new ways of looking at things. So thank you very much. Really enjoyed it. Okay, questions. Does anybody have a question?
And if you look at the slide deck, there's going to be other things in there that I didn't touch on. So going back and looking at those studies, and going through that slide deck. And look, I love speaking with your class, Rowena, so I'm always happy to come back and speak again when it works into your schedule.
Oh, thank you. That would be wonderful. I think it's a really unique opportunity to look at some of these issues with the knowledge and insights that you have. So it's extremely valuable.
Well, and I always want to call out, we all get to do this together, right? I get to work with incredible teams of people, and the knowledge comes from lots of time of reading. And I'm still that guy that, I'll literally print stuff with a highlighter and a pen, and I'm highlighting papers. And I think part of that's really important because that's what drives knowledge deep into your brain. And sometimes you just have to struggle with these concepts, and you just got to work through them, and you got to reread it, and it can be frustrating because you want to get it the first time. A lot of this stuff that I'm talking about today, I've literally reread 5, 7, 10 times. So anybody can learn all this. It just takes hard work, and all you guys are incredibly bright. You've got a wonderful teacher. So just take the time, a highlighter and a pen and a piece of paper, and you'll figure it out.
Really good advice. Thank you. And yes, I agree. You can't beat the sort of old-fashioned approach of having something in paper in front of you with the highlighter pen.
Yeah, that's called active learning. Active learning.
Okay, any questions, or doesn't have to be a detailed question, even a general question anybody would like to ask?
Rowena, can I ask a question?
Yeah, sure.
Like, if people were going to go into a medical specialty, what are people thinking? What is this group? What are some of the thoughts they're aiming at?
Got one question in the chat, but before we go to that, that's a question for all of you. Do you have any firm ideas yet about what you're thinking in terms of medical specialty, or are you wanting to go through medical school and then make a decision sort of later on? What are your thoughts at the moment?
Hopefully some people have an interest in aerospace medicine.
Yeah, I'm hoping.
So pretty much up in the air, would like to figure things out through clinicals. Amen. I think that's a good approach. Let me approach Harlan's really smart question. What do you think of generating negative pressure towards the bottom of the person approach solution for microgravity? So there's a device on the station called the Shiba, and I believe it's a Russian device, but it's basically a device you sit in that creates big, long, over basically from your axilla down, negative pressure to do exactly that. There are people, and I didn't get into the slides, who actually will sleep. There's been astronauts who will sleep in a head down tilt because one of the space analog space flight models is head down tilt 6 degrees. That creates the same kind of fluid distension. And some astronauts have slept like that for a couple of weeks before they go into space. They find they have much less symptoms once they get into space, which I think is incredibly interesting. The Shiba suit, where you apply this negative pressure, the Russians, from what I understand, do it different than the Americans, where the Russians will use this device for a few weeks before they land back on Earth to take away some of the orthostatic hypotension. It's to sit in this big kind of can and have this negative pressure applied. You got to be careful, because I remember reading about Scott Kelly when he did this, and he says, I almost passed out. We got up to like minus 75, and all of a sudden he had such a dramatic fluid shift that he started to get really fuzzy thinking. So it can really affect fluid shifts, but it's a big device. If somebody can figure out how to micronize it and still get the same effect, that's going to be very helpful. And then preconditioning before you go into the weightlessness of space may also help management of these symptoms. Personally, I want to go through medical school before deciding. That's a great. Surgery, plastics, or aerospace. Love that answer. I'm still open to learning new things and being introduced to new possible pathways, radiology and respiratory sleep. Wow, there's so many people struggling with sleep in the world right now. That's a great field. Aerospace medicine seems mysterious. It is, and it's super fun. Do you think that a pharmacologic solution to regenerate endothelial glycocalyx should be investigated for prevention of atherosclerosis in at-risk patients? So look at, that's actually the study that I got to participate in with injuring a carotid artery on a mouse. at Northeastern University in Boston, and using something called micronized purified flavonoid fractions, or MPFFs. And basically it's like 20 orange rinds in one pill. So diosmin hesperidin is what this MPFF is. And we showed for the first time ever that diosmin actually helps regenerate the endothelial glycocalyx. Now, more clinical studies have to be done, because right now MPFFs are used internationally for veins and lymphatics. No one's really using it for arterial disease, but I think that it's incredibly important for arterial disease. And I could see a point in time in the next 5 to 7 years where every diabetic is put on micronized purified flavonoid fraction to do exactly what you're talking about, with helping prevent glycocalyx degeneration in our diabetics, because then ideally they don't lose their eyesight, they don't lose their kidneys, they don't have neuropathy, and they don't lose a limb. So I think upstream thinking on this will really help. The other nice thing about flavonoids is it increases insulin sensitivity to cells. So I think that's a really good thing boy, if one of anyone here can take MPFFs and figure out the clinical application, it's going to be incredibly helpful. I plan on applying in the US for residency. Do you know if international students, I'm Canadian, are even able to get jobs with NASA, SpaceX, or other space agencies without US citizenship? Rowena, I don't know that answer, but I think having a US citizenship is always beneficial if you're pursuing those types of roles. But again, private, astro civilians, and obviously there are, New Zealand, Australia, there's other entities that are now growing their space program. But I think it, and I could be wrong on this, but I think it may be a benefit to get US citizenship.
If I can just interject there, I do
Yeah.
know the answer to this, because I've had to look into it recently, and at the moment the answer is pretty much yes. You do have to be a US citizen, because there are these laws in America which are called ITAR and EAR, which govern the export of sensitive information in defence and aerospace and so on. So unless you can be one of the people who gets an exemption to that, and that sometimes does happen. For instance, people who are doing post-PhD fellowships at NASA, for instance, can be overseas people. But as a general rule, you have to be a US citizen. However, I did find out the other day from a US colleague that the NASA Aerospace Medicine Clerkship, which they run a couple of times a year, there actually is a pathway for Canadians to go and do that clerkship. So that's probably something useful to keep in mind.
Thank you for clarifying that. In terms of medication to decrease fluid accumulation in the head, how far do you think we are in finding this drug, and what do you think the key targets are? I think it's going to be, because it's a multi-hit hypothesis, I think it's going to take multiple things to help. It would be great to figure out how to sleep in a supine fashion in space, like you're sleeping flat. Because my biggest concern is for long-term brain health. If you're talking about a flight to Mars, time on the moon, you're subjected to a much longer period of changes within the brain. So I think figuring out circadian rhythms, figuring out how to sleep flat, how to make sure the G lymphatic system is maximally functioning, and then decreasing overall time in space. So ideally with nuclear-based power sources for engines, as was just approved and working on, that's going to literally cut in half the time to Mars and back. That's a huge opportunity to helping to protect the astronaut crew. Plus you need less food, you need less, it just makes everything better. I'm looking at anesthesia and aerospace, wonderful. Also, if we were to generate these drugs, do you think they will have an impact on health conditions down on Earth? That's called a spin-off. Absolutely. So NASA's already created many dozens of spin-offs in terms of Saturn, the Apollo program, Skylab, the shuttle program and the space station that have all spun off into how we can treat patients better on Earth. NASA publishes a free book every year. If you get onto the NASA website and put in spin-offs, I believe you'll be able to download their yearly book that talks about exactly this types of thing. I'll follow up with an email to you about that if I could please get some more information. Absolutely. And looks good. And I'm going to send Dr. Christensen 3 papers. One is from Vanderbilt about the sodium impact on women with lipedema. It was a 5-woman study. And then 2 papers on how salt changes dermal lymphatic health in the glycocalyx. I think this is going to be one of the most important things coming up is prevention and recognizing the amount of sodium in our food. And the most cost effective, because instead of adding something in, we're just going to take away something and eat better. So I think we really do have to look better at how much sugar we're consuming and how much salt we're consuming, because those 2 things together do more damage to your vasculature than a lot of other things in the environment.
Well, it doesn't look like there's any more questions, unless we have any last minute things anyone would like to ask before we finish up. In that case, could we please say thank you very much to Dr. Melin for a wonderful presentation, and also for the great answers to all the questions. And I will share the slide deck with you, and also those papers. And thank you in advance for sending those papers. I really appreciate it, and especially while you weren't feeling well, that was very generous of you to still come along and talk to us today.
My apologies for the intermittent coughs, and thank you for tolerating it. All right, y'all have a great Monday, and Rowena, thank you again for the privilege of being able to present to your class. I loved it.
Thank you very much. Hope you feel better soon.
No worries. Thank you. All right, bye.